Hi, greetings from Chennai. Roy Santosham is my name, and I have been working in Sri Ramchandra Medical College, Chennai since 1993, and I've been a professor in radiology in the same college for 17 years. I've been a proud member of IRIA since 1990, and I served as a president of IRIA Tamil Nadu Pondicherry chapter between 2013 and 14. I was invited to deliver the prestigious Professor Arthur Daniel Memorial Oration in IRA Tamil Nadu and Pondicherry chapter in 2012, and I'm a co-inventor of PIGA CT, the winner of Frost & Sullivan Product Innovation Award in the year 2009. And I'm here to speak about my new invention, the Highnoon CT navigation device. I developed this through the company that I founded along with my partner, Mr. Shant Kumar, and the seed fund for developing this device from Government of India, DBT BIRAC. We won the prestigious Medical Make in India Innovation Award in the year 2017. We got the gold medal, and we got the Indian patent in 2016 and the Chinese patent recently in 2021. The US patent and the European Union patent are soon to come. As you all know, CT was not invented with an intent to guide intervention. But because of the immaculate cross-sectional images that we get, radiologists could not resist the idea of sticking in needles looking at CT images. If one can place a needle with precision within this body, looking at these CT images, whole lot of interventional procedures can be done in the CT room. The bread and butter regulation procedure is our biopsies, which are done not only to diagnose malignancies, but also in our country plays a very important role in diagnosing extrapulmonary tuberculosis. We can drain unwanted, difficult collections which are not seen by ultrasound. We can manage pain. This is a patient with intractable trigeminal neuralgia, a needle placed precisely in the foramen of ovale. We treat tumors percutaneously by radiofrequency ablation or by microwave. You can see the excellent results after 10 months. We can tattoo nodules and render them visible on surgery. And we can even percutaneously fix complex pelvic fractures, as you can see. And the key to all these procedures is precision and precise needle positioning, for which a radiologist should know the target, the point of entry, and the all-important angle of incidence. Now, this angle can go wrong in two planes. One is in the left to right direction, and the other is head to foot direction. Even a few degrees of angular error can deflect the needle off the target, and this can result in repeated needle insertions or manipulations, which can result in pain, discomfort, prolonged procedure time, more radiation, not to forget more complications, can even at times lead to death. Now, the fear of insertion of needle in the required angle of incidence is what keeps radiologists from embarking on these procedures. There are nearly 20,000 radiologists registered with IRIA, and there are 3,000 to 3,500 CT scanners in our country. According to the needle vendors, there are 1,500 to 2,000 radiologists who embark on these procedures. Out of them, only a handful, less than 100, would target lesions which are less than 1 centimeter, and those which are precariously close to vital structures. Now, our device boosts confidence and enhances accuracy and safety, so that we make this available for more radiologists to do these procedures, so that for the benefit of our patients. Our device is ceiling mounted, and it can be easily pushed to the place of interest. It has a central camera, 4 sources of light, and a laser source which projects a crosshair on the patient. The intersection of this crosshair falls on the center of the camera's field of view. The device has a left to right and a head to foot swinging action. We have a monitor in the CT scan room which shows a real-time feed from the camera, and at the center of the monitor you have a green circle which is a virtual circle, and by virtue of being at the center of the monitor, it is aligned to the center of the camera's field of view. And we have a virtual crosshair which intersects at the center of the green circle, and the image of the projected crosshair superimposes precisely on this virtual crosshair. From the CT images, the radiologist chooses the target and the point of entry. You can see the target and the point of entry need not be on the same slice. And like in a freehand procedure, the radiologist marks out the point of entry and he places a radio-opaque fiducial on the point of entry, and we do a check scan. And if you are happy with the position of the radio-opaque marker, then we send these images to the console of the device wherein the point of entry and the target are re-registered. Having done that, when you hit the calculate button, you get to see the virtual track of the needle and also the depth to which the needle has to be inserted. Having done that, when you hit the start button, the device tilts to the necessary angulation. The tilted device can be easily aligned to the point of entry by moving the table with the patient on it and the tilted device, so that the crosshair intersection falls precisely on the point of entry. When you get this alignment, the image of the point of entry will be projected perfectly within the green circle. Then you load the needle to the desired depth, and when we take the needle to the point of entry, by virtue of these 4 lights that we have, we get 4 shadows. Now we have to align these 4 shadows to these laser grids. We insert the needle in slow increments with breaks in between to confirm the alignment. So once we get this alignment right, the image of the back of the needle will be projected within the green circle, and the laser crosshair intersection will fall at the back of the needle. Then we know that we are in right alignment, and you can see the needle in the right position. Okay, what are the advantages of this device? There is no need to push a heavy device by the side of the patient. No complicated reconstructions need to be done, which is time consuming. The needle is not held by an external device. This is a great advantage because freehand needle, we can actually combine it with a CT fluoroscopy in the quick check mode. The patient movement can be detected and it can be corrected, and respiratory inconsistency can be negated. I'll show you how. We make 4 points on the laser grids. Now imagine this patient has moved. We can easily bring back the patient to the original position by aligning the 4 points. Similarly, here is a patient who is breathing. You can see the respiratory excursion. By just verbal command to exhale, exhale, and you can ask the patient to hold the breath now. This is of a great advantage when you're doing procedures under GA, because you're giving a visual feedback to the anesthetist to hold and give you a consistent respiratory phase of breath hold. Well, the clinical validation was done in Christian Medical College, Vellore, by none other than Professor Shyam Kumar. He did 30 procedures with our Highnoon device and 30 freehand procedures, and he found that the time taken was less when he used Highnoon. The errors were less, and also the radiation was less, as there was fewer need for check scans. We have done more than 500 procedures using our device. I will show you a few. This is the patient with the left upper lobe mass, which is deep-seated. This is our planning on our console, and that is a needle. This is a subcarinal lymph node planning and the needle in position. This is a tricky case wherein the lesion is on the diaphragm, and you can know because of the diaphragmatic movement, the lesion can be moving, but because of the respiratory consistency that we could achieve, we were able to correctly place the needle on the lesion. This is a small little nodule deep in the lung, which is banged behind a rib, which this is the planning with the caudal angulation, and this is the precise placement of the needle. This is a patient with left lower lobe mass who was to undergo microwave ablation. We have placed a needle in the thoracic paravertebral space for need of anesthesia, and then we have done a microwave ablation. This is a transpedicular biopsy of T4 vertebra. And this is a very tricky case, a lesion which was in the anterior mediastinum, right behind the sternocostal junction, which was perfectly accessed, which was very close to the aorta. Well, with this Highnoon, the device enhances accuracy and confidence. It brings down the procedure time significantly, reduces pain and discomfort to your patient, reduces radiation. It's easy to use. No prolonged training is needed with an application specialist. It is potential to make state-of-the-art CT fluoroscopy simpler. Our strengths, our workflow you could have seen, it is almost the same as your freehand technique. The problem of patient movement and the respiratory misregistration has been addressed. It is all at an affordable cost. Thank you so much.